I just have to pause for a moment. Good afternoon, or whatever time period it is where you are. Welcome to Preventive Medicine Grand Rounds for March 2nd, 2022. I'm Antonio Neri from the Division of Scientific Education and Professional Development. The Preventive Medicine Grand Rounds is sponsored by the Centers for Disease Control and Prevention's Preventive Medicine Residency and Fellowship, as well as the Health Resources and Services Administration Bureau of Health Workforce. The PMRF, as we call it here at CDC, provides a 12 and 24-month full-time longitudinal service learning opportunities with senior public and population health leaders to physicians, veterinarians, and nurses who have completed the Epidemic Intelligence Service Program or have equivalent public health experience. You can see we use Zoom for audio and presentation and the question box to pose questions. Note you can pose questions via the question box at any point during the lecture, and Dr. Blanchard will work on answering them at his discretion. Note your name may appear associated with the question you pose. If you do not want your name to be associated with the question, then please check the Submit Anonymously box. Continuing education credits are available for the live course up to 1 month after the presentation date, and for the recorded version up to 2 years from the date of the presentation through the CDC Training and Continuing Education online portal. The course code for this Grand Rounds is all capital letters CDC PMRF. You can find more information about continuing education credits on our website, cdc.gov/prevmed. Any questions if you might have, please contact myself or email the program at prevmed@cdc.gov. I wanted to take a time for one announcement in that we still have openings for our Population Health Training in Place program. Our application is still open through March 15th, of which Dr. Blanchard is a current participant. We're very happy to have him and would hope to have you apply for our 2022 class as well. And from that, I can't think of anything else at the top of my head, but please remember that the views presented by the speaker are theirs alone and do not represent CDC, the Department of Health and Human Services, or the US government. Before we start with the title, we'll take our usual moment of silence for our colleagues, friends, and families who've dedicated their time, energy, and sometimes lives fighting the COVID-19 pandemic. Okay. All right. Today's Grand Rounds will be entitled The Foundations and Frontiers of Addiction Medicine by Dr. Jeremy Blanchard. Again, a resident and a learner in our Population Health Training in Place program. Very excited to have Dr. Blanchard present on his work, and hope you enjoy it as much as we've enjoyed working with him this last year. The presentation will be approximately 1 hour, followed by 30 minutes for questions and answers afterwards. Thank you, Dr. Blanchard. The floor is yours.
Thank you so much for the kind introduction. So my name is Jeremy Blanchard. I'm a member of the CDC's Population Health Training in Place program in class of 2021. In my current clinical role, I'm an addiction medicine fellow at the University of Washington Boise Addiction Medicine Program. I'm also a PhD candidate at Thomas Jefferson University in Population Health Sciences with an emphasis on applied health economics and outcomes research. My doctoral work is on evaluation and economic simulation of Medicare for All in the United States. At Jefferson, I'm also a lecturer and teach the principles of epidemiology and foundations of the US healthcare system. Today, I have the pleasure of speaking with you about the foundations and frontiers of addiction medicine. In today's talk, we'll take a look at the practice of addiction medicine, current trends in the epidemiology of substance use, and different training pathways. Finally, I'll discuss some of the research that I'm currently involved with. I have no relevant financial relationships or non-financial relationships to disclose. So I have today's Grand Rounds broken up into 5 sections. First, we'll talk about use of appropriate terminology in addiction medicine. There's significant historical context contributing to the use of stigmatizing language regarding substance use, and I'll spend some time discussing the use of non-stigmatizing language. Next, we will discuss current trends in epidemiology of substance use and take a close look at the most recent results of the National Survey on Drug Use and Health. In the following section, we will discuss clinical practice of addiction medicine, reviewing pertinent neurobiology and pathophysiology, diagnosis and treatment with a special focus on alcohol, opioids, and nicotine. I will then spend some time discussing some of my current research, evaluating the impact of prescription opioid limits. This work is especially pertinent with the recent announcement of CDC's updated clinical practice guidelines for prescribing opioids. Finally, we will discuss training and experience pathways for those interested in learning more about how to incorporate addiction medicine into your current practice. Intentionally, I'd like to start today's talk by discussing appropriate terminology in addiction medicine. There's a long history of use of stigmatizing language regarding substance use, and I'd like to spend some time discussing the use of non-stigmatizing language. Like most things in medicine, there's a period of catch-up required in both practice and common dialogue. I do sincerely appreciate the number of individuals who reached out to me personally after the press release for this Grand Rounds, noting the use of the term substance abuse. This actually prompted me to move this section to the beginning of the lecture so we can go over some appropriate non-stigmatizing terminology. Two of our leading organizations in addiction medicine, the National Institute on Drug Abuse, NIDA, and the Substance Abuse and Mental Health Service Administration, or SAMHSA, as I'll refer to those during the talk, have both released a number of publications on non-stigmatizing language, which I'll now discuss. Stigmatizing language is detrimental in all settings, clinical or non-clinical. Addiction medicine is particularly vulnerable based on a long history of antiquated and incorrect assumptions that addiction's actually a moral failing, rather than a chronic and treatable disease we now know it to be. When I use the word stigma, I'm referring to language which discriminates against groups of people, places, or nations. There are dire consequences of stigma in individuals with substance use disorder. Stigma can reduce willingness of individuals with substance use disorder to engage in treatment. It can also lead to stereotypes, which lead to social distancing from individuals with substance use disorder. It can also negatively impact a healthcare provider's perception and the subsequent care that they deliver to individuals with substance use disorder. With this in mind, there are a few steps that can be taken to reduce stigma in this field. Using person-first language, i.e. a person with substance use disorder, conveys a neutral tone and distinguishes individuals with from their diagnosis. We don't go around the hospital saying we need LFTs on the cirrhotic in bed 3 or get pneumonia on an encephalopathic patient in the ED. We refer to them as patients, and we try to use patient-centered language. And addiction medicine is no different. Persons with substance use disorder should be treated no differently. It should not be referred to terms like addict or drug abuser. A common term which can lead to stigma is habit, which in many ways undermines the severity of disease. It also is reductive and creates a sense that an individual can merely choose to stop. Abuse is also a major culprit for stigma and one of the more commonly misused terms. More patient-centered language would include use for illicit drugs and misuse or used other than prescribed for prescription medications. Terms clean and dirty have also long been used to describe negative and positive toxicology screen results, especially in the context of urine. Aside from being clinically inaccurate, this terminology is stigmatizing and can have a major impact on an individual's hope and self-efficacy for change. Now that we've discussed some basic groundwork for a non-stigmatizing approach to language in addiction medicine, let's take a look at some current trends in substance use in the United States. According to CDC's National Center for Health Statistics, an estimated 100,306 drug overdose deaths occurred in the US during the 12-month period ending in April of 2021. This represents a 28.5% increase from the year prior. It is absolutely imperative to understand trends in substance use that have contributed to this massive increase in overall deaths. The Department of Health and Human Services and SAMHSA, the Substance Abuse and Mental Health Service Administration, published the 2020 National Survey on Drug Use and Health in October of 2021. These surveys are among the most helpful studies in truly understanding the impact and trajectory of substance use in the United States. Importantly, this most recent iteration utilized web-based interviewing for the last quarter from October to December, largely impacted by COVID, and evaluated the impact of COVID-19 in substance use. In this section, we will specifically look at trends in all substance use, tobacco products and nicotine vaping, alcohol use, opioid use, and stimulant use. Before we take a look at some current trends of substance use, it's important to provide some context into the categorization of substances. The American Society of Addiction Medicine, or ASAM, put substances into 6 categories of psychoactive drugs, though this list is not all-inclusive, which we'll discuss. Central nervous system depressants include agents like alcohol, benzodiazepines, barbiturates, and GHB. The opioid category includes both prescribed and illicit opioids and includes morphine, hydromorphone, heroin, oxycodone, hydrocodone, codeine, methadone, fentanyl, and buprenorphine. Stimulants includes cocaine and amphetamines, cathinones, methylphenidate, caffeine, and nicotine. The cannabinoid section includes cannabis and synthetic cannabinoids. The hallucinogen section includes LSD, psilocybin, mescaline, MDMA, and belladonna alkaloids. And finally, the dissociatives and anesthetics section includes PCP, ketamine, and dextromethorphan. Again, this list is not all-inclusive, but it is important contextually when we look at trends in substance use in the US, as well as for our discussion on neurobiology and pathophysiology. It's also important to note that not all substances fit nicely into a single category. Kratom, for example, part of the mitragenous species, which is widely available in many states, exhibits stimulant properties at low doses and opioid properties at higher doses. It's also important to note that not all of these agents are illegal or even typically thought of in the context of disordered use. If you include caffeine, it's likely that the vast majority of individuals at one point or another have experienced a psychoactive substance. So in 2020, approximately 59% of individuals aged 12 or older used tobacco, alcohol, and/or an illicit substance within the past month when they were surveyed. We define this as current use and can see that this equates to approximately 138 million individuals drinking alcohol, 51 million individuals using tobacco products, and approximately 37 million individuals using illicit drugs. Illicit drug use was reported in approximately 13.5% of the US population aged 12 or older. While not all of these counts by any means qualify as use disorder, it's easy to see the significant prevalence of substance use in the United States. Now, let's take a closer look at the breakdown of illicit drug use during this time period. Here we can see illicit substance use within the past year during 2020 in people aged 12 or older. In the last figure, we saw that 13.5% of this population had used an illicit substance within the past month. Here we can see that over 1 in 5 individuals, or 21.4%, had used an illicit substance over the past year. Again, this is use, not diagnosed use disorder. Cannabis is by and large the largest area of use and categorized here illicit under federal law. Percent use was highest amongst those aged 18 to 25 at about 11 million individuals, accounting for nearly 35% of this age group. After cannabis, misuse of prescription pain relievers, such as opioids, were the next highest, accounting for approximately 3.3% of this defined population. You can see that misuse of prescribed opioids were approximately 10 times higher than heroin use, which was accounted for approximately 902,000 individuals. This trend demonstrates the significant impact of prescription of opioids, which I'll discuss in much greater detail when I talk about some of my current research related to the CARE 2.0 Act, the Comprehensive Addiction and Recovery Act. One of the biggest improvements in the National Survey on Drug Use and Health in 2020 was the inclusion of nicotine vaping, which was prompted by significant increasing trends since 2014, demonstrated in a number of other studies, including the 2018 National Youth Tobacco Survey and the 2019 Monitoring of the Youth Survey. The category of nicotine and tobacco is now divided into cigarettes, cigars, smokeless tobacco, pipe tobacco, and nicotine vaping. Among those aged 12 or older, approximately 20.7% were surveyed as currently using with use of tobacco or nicotine vaping within the past month. The percentage was highest amongst young adults aged 18 to 25. Among those using nicotine products, nearly 2/3 of adolescents aged 12 to 17 who used nicotine products within the past month vaped nicotine. Approximately 3.8% of the total population used an e-cigarette or another vaping device within the past month during this survey. It is imperative to understand this trend, especially in regards to adolescent use patterns, to best inform future policy impacting nicotine vaping in this population. Among the highest use of psychoactive substances is alcohol. Of respondents aged 12 or older, approximately 138 million individuals drank alcohol. Of these individuals, approximately 44% qualified as binge drinking alcohol use, defined as 5 or more drinks for males or 4 or more drinks for females on at least one day within the past 30 days. Furthermore, approximately 13% qualified for heavy alcohol use, defined as binge drinking on 5 or more days in the past 30 days. The percentage of those consuming alcohol with both binge alcohol use and heavy alcohol use was highest in young adults aged 18 to 25 at approximately 31.4% and 8.6% respectively. Again, a close understanding of these use patterns provides a great opportunity to target efforts aimed at reducing use patterns that may result in substance use disorder. Much of the clinical efforts of addiction medicine specialists are focused on the treatment of opioid use disorder, often associated with pain reliever misuse. In 2020, approximately 3.3% of those surveyed in this population had misused a pain reliever, with the largest percentage misusing hydrocodone at 1.7%, followed by oxycodone at 1.1%. The most common reason respondents described for reasons for misuse was to relieve physical pain, accounting for approximately 65% of those respondents with misuse. A much lower proportion reported misuse for reasons such as euphoria or to relax, which were both around 10%. Switch our talk a little bit to stimulant use. So the vast majority of methamphetamine used in the United States is actually produced and distributed illicitly. Because of the different nature of prescription stimulant misuse and methamphetamine use, SAMHSA separates these into distinct categories. You'll note in this figure, there are trends by age group, though the authors warn on comparison of estimates mainly secondary to methodological changes in the 2020 survey, which were affected by the COVID-19 pandemic. And speaking of the COVID-19 pandemic, approximately 10.3% of the past year's users of substances other than alcohol endorsed that they perceived that they used substances a little more or much more during the COVID-19 pandemic. Interestingly, approximately 1 in 3 respondents indicated that they perceived decreased use during the pandemic. Now, let's take some time to discuss some foundational topics of the clinical practice in substance use disorders, including the neurobiology of addiction and a review of some of the FDA-approved medications for selected substance use disorders. Addiction can be defined as a chronic relapsing disorder characterized by persistent drug pursuit and use despite adverse consequence. Above all else, substance use disorder is a chronic disease which requires close consideration of physiologic, genetic, and psychosocial factors. Treatment is similar to other chronic illnesses. I'll emphasize this point many times during this presentation. It requires a multimodal approach. A parallel that we frequently draw in addiction medicine is to type 2 diabetes. Treatment requires careful consideration of baseline characteristics of genetics and environmental factors, with significant consideration of lifestyle factors, like in this example would be diet and exercise. Like many other chronic illnesses, a disease may not be able to be cured, but targeted treatment can treat disease, leading to improved quality of life and decreased complications. With that, there are a number of neurobiological mechanisms at play, which help explain the physiology of addiction. There's not a single reason that individuals use substances, and it's important to recognize that reasons for initial use are not necessarily and often not related to reasons for persistent use. Many substances can produce the sensation of euphoria, especially with initial use. And euphoria it's subjective and can mean different things to different people. The euphoria that one gets from cocaine, for example, often produces feelings of self-confidence or increased energy. The euphoria that one gets from using heroin, on the other hand, may increase feelings of relaxation or satisfaction. Common amongst substances is the positive neurobiological feedback loop, producing positive reinforcement with use and negative symptoms with withdrawal. We'll talk a little bit more about this. There's a large proportion of individuals also with co-occurring mental health disorders that use substances in order to feel better, to treat stress, to treat depression, and even treat social anxiety. Now let's discuss a little bit of neuroanatomy in context to addiction. The basal ganglia is one of the key areas associated with the brain's reward circuitry. It helps play an important role in positive forms of motivation, from socializing to sex to eating. The basal ganglia is largely responsible for humans' development of routine. Substance use tends to overactivate this reward circuit, leading to euphoric response. Repeated exposure, though, diminishes sensitivity and leads to increased use to experience the same or even diminishing effects. The amygdala is largely involved with the experiences of irritability, anxiety, experienced with withdrawal from substance use, involved with the reward pathway. The pathways associated with the amygdala become highly sensitized with increased substance use. Over time, even if an individual no longer experiences the positive euphoric effects of a substance, they still experience significant discomfort associated with withdrawal because of sensitization of the amygdala. Finally, the prefrontal cortex is largely responsible for our ability to think, plan, and make decisions. It's the last part of our brains to fully develop in late teens, which makes teenagers uniquely susceptible to substance use. There are many other areas of the brain involved in the complex process of addiction, but these three main areas are largely involved and implicated. The complex interplay between reasoning and the prefrontal cortex, balanced with the more primitive areas of the amygdala and basal ganglia, are largely implicated in substance use disorders. Neurotransmitters are also highly involved with this described feedback loop and reward pathway. Dopamine is largely implicated in this pathway in an area of the brain known as the nucleus accumbens. Substances like cocaine increase dopamine levels in a number of different areas in a process known as tolerance, whereas increased amount of substance are required to produce similar physiologic effect. Again, this process frequently switches from cravings to produce a pleasurable response to an aversion of withdrawal symptoms. Again, to emphasize, the goal of substance use treatment is to counteract the disruptive effects associated with neurobiological responses and behavior and to help maintain recovery. Recovery does not equal cure, but does represent an individual's ability to regain control of their life. So while discussing all the diagnostic and treatment modalities for substance use disorders is far beyond the scope of this lecture, I did want to introduce some FDA-approved treatments for alcohol use disorder, smoking cessation, and opioid use disorder. Currently, naltrexone, including extended release, acamprosate, and disulfiram are FDA-approved for the treatment of alcohol use disorder. It's important to note that treatment is different when patients are in a withdrawal state from alcohol and can have life-threatening symptoms, including seizures or delirium tremens. Nicotine replacement therapy, like patches and gum, bupropion, and varenicline, are currently FDA approved for smoking cessation. For opioid use disorder, buprenorphine, methadone, and naltrexone, including extended release, are currently FDA approved. I also include naloxone here for opioid overdose prevention. If there's one takeaway from this lecture, in addition to terminology and the chronic disease model, it is that naloxone saves lives for those who use opioids. Naloxone is a high affinity antagonist of the mu receptor, which opioids work on. Naloxone can reverse the effects of opioids and prevent overdose deaths caused by respiratory depression, sedation, and hypotension. Before we talk a little bit more about buprenorphine, I wanted to briefly discuss screening for opioid use disorder. This should be a practice for all primary care providers or any providers prescribing opioids for that matter. If a provider does not offer medications for opioid use disorder, they should be aware of resources to get their patients access to treatment for opioid use disorder. They should be comfortable assessing for co-occurring medical disorders like HIV and hepatitis C and be able to provide overdose prevention education with prescription of naloxone. It's imperative to establish follow-up with these patients regardless of referral. For those providers who do offer medications for opioid use disorder, the provider should be able to do all of these things mentioned previously, in addition to determining opioid use disorder diagnoses and severity. I do want to briefly discuss, again, not all-inclusive, but discuss the use of buprenorphine in the treatment of opioid use disorder. Buprenorphine has partial mu agonist effect, again, mu being one of our opioid receptors, with a well-described ceiling effect. So it's much less likely to cause respiratory depression than other full mu agonists. Buprenorphine is preferred in most cases with naloxone, which has minimal systemic absorption when taken orally with buccal absorption, but will precipitate withdrawal if injected. Naloxone does not change the bioavailability or effect of buprenorphine, and again, has very low to no sublingual bioavailability. So essentially inert when taken appropriately. So the dose range recommended for Suboxone, or which we call this a combination of buprenorphine and naloxone at a 4-to-1 ratio, is recommended is between 2 and 24 milligrams of buprenorphine per day. There have been a number of studies, including a number of randomized control trials, which have demonstrated maximum effective dose at 32 milligrams. This means that beyond that, increased doses beyond this will not affect proportional serum levels, with serum levels plateauing at that 32 milligram dose. Another important point to emphasize is the improved safety and decreased diversion risk associated with the combination product of naloxone. Cross-sectional studies have demonstrated higher rates of diversion with monoproducts, so just buprenorphine by itself, when compared to buprenorphine with naloxone. Some of the commonly cited reasons for diversion include peer pressure to share medication, to help family members with substance use disorder, and to sell. I do want to emphasize this. Anecdotally, a large reason we in addiction medicine see for diversion is attempting to help other family members or loved ones who are actually trying to get substance use treatment that don't have access to medication otherwise. So while I use the diversion term here, when we talk about diversion, it's usually going to help with treatment. Next, I'd like to take the opportunity to discuss some of the research I'm currently involved with as part of my population health training in place policy analysis on the impact of the opioid prescription duration posited in the CARA 2.0 Act. There are an estimated 3 million individuals in the US currently meeting criteria for opioid use disorder. That's 914 cases per 100,000. It's estimated that nearly 50,000 individuals die annually from opioid-related overdoses, secondary to the misuse of prescription pain relievers, heroin, and synthetic opioids such as fentanyl. Opioid misuse also leads to significant morbidity and mortality, including increased transmission of HIV and hepatitis C, increased incidence of neonatal abstinence syndrome with about 6.5 cases per 1,000 deliveries, and mortality related to motor vehicle collisions at approximately 5% of all fatal two-vehicle crashes that are associated with opioids. To help address the opioid epidemic, Congress has introduced the Comprehensive Addiction and Recovery Act 2.0, a revision from CARA 1.0, which is a bipartisan bill that was passed in 2016 that established significant funding for education, treatment, and recovery in addiction medicine. Of note, the new bill has suggested language of a day limit on initial opioid prescriptions for patients with acute pain. This is aligning with some of CDC's previous 2016 guidelines for prescribing opioids for chronic pain. While these guidelines were developed for chronic pain, data from CDC suggests that long-term opioid use frequently begins with the treatment of acute pain. In order to explore the potential impact of a day prescription opioid limits, I'm working with Idaho Medicaid to assess the impact of initial opioid prescription duration and the likelihood of subsequent prescription. The Comprehensive Addiction and Recovery Act, again 1.0, was signed into law on July 22nd of 2016. The law established innovative strategies to address the opioid epidemic in the United States, including coordinated care for individuals with substance use disorders and their families. The 6 pillars of CARA are prevention, treatment, criminal justice reform, law enforcement, recovery, and overdose reversal. Long-term opioid use often begins with the treatment of acute pain, which is one of the major cited drivers of the 2016 CDC guidelines for prescribing opioids for chronic pain. This specifically included recommendations for the duration of opioid therapy for acute pain and the type of opioid selected at initiation. The data is still largely lacking delineating the transition between acute to chronic opioid use. In their seminal work, authors Shaw, Hayes, and Martin out of the University of Arkansas in 2017 did describe some major characteristics of initial prescription day supply and the probability of continuing use at 1 and 3 years. They found that the probability of long-term opioid use increased most sharply during the first few days of treatment, particularly after that 5-day mark. Rates were relatively low, only 6% at 1 year for those prescribed at least 1 day of opioids, but increased drastically to 13.5% after 8 days and to 29.9% after 31 days. So in order to increase funding authorization levels from the original Comprehensive Addiction and Recovery Act, Senators Portman, Whitehouse, and Klobuchar introduced CARA 2.0 in an effort to further combat the opioid epidemic in a bipartisan fashion in 2018. Highlights from this proposed bill included creating a national standard for recovery residences, allowing advanced practice providers to prescribe buprenorphine, and requiring physicians and pharmacists to use state prescription drug monitoring programs when prescribing and dispensing opioids. One of the aspects of the bill that received quite a bit of attention was the recommendation of a day limit on the initial opioid prescription for acute pain. Again, not chronic pain, but the initial opioid prescription for acute pain. While many parts of the bill have since been realized, and CARA 3.0 is already being introduced in the Senate with goals of expanding access to evidence-based medication-assisted treatment, implementation of day limits of initial opioid prescriptions has received mixed support, most often citing the lack of correlation that delineates that transition from acute to chronic opioid use. So, in an evaluation by Zhang et al. On state opioid limits and volume of opioid prescriptions, historical trends were analyzed which demonstrated overall decreasing number of opioid prescriptions in both states with and without opioid limits as of December 31st, 2018. They did find a 7% total reduction in the number of opioid prescriptions in states with legislative limits on initial opioid prescriptions in Medicaid enrollees. In an analysis of 26 states' Medicaid populations, implementation of opioid limits demonstrated a decrease in approximately 0.8 per 100 Medicaid enrollees, representing an equivalent of a 6.9% reduction compared to predicted rate with no limit. Their historical analyses also demonstrated significant impact in reduction of opioid prescriptions based on PDMP, prescription drug monitoring program requirements, and increased prescriptions with the Medicaid expansion, which makes sense as an increasing total population of Medicaid would indicate increased prescriptions. So in order to assess the impact, delineate this area from acute prescription to chronic prescription on the initial duration of opioid prescriptions for acute pain on the likelihood of subsequent prescription, our aim is to perform a retrospective analysis of prescriptions of Idaho Medicaid enrollees for a 1-year period. The goals of this project are multifaceted, with the main goal of determining if there are correlation between initial opioid duration, those how many days initially prescribed, and the morphine milligram equivalent, or MME, on defined opioid naive patients, and the likelihood that they will be prescribed opioids at a later date within the defined timeframe of the study. Significant policy and research has suggested a strong relationship between these factors and has led to suggested opioid prescription drug limits in the most recent proposed legislation, as we discussed in CARA 2.0. Other aims of this study will be to assess the impact of provider type on initial and subsequent prescriptions, to assess the impact of initial opioids on subsequent prescription, and to assess the impact of demographic characteristics on initial and subsequent prescriptions, and finally, to assess the geographic variance on initial and prescription opioids. I'm quite hopeful that we can provide further evidence on the relationship between initial opioid prescription duration on likelihood of subsequent prescription and add to prior work which can help inform policy. This work is especially timely as CDC has recently released a draft of updated clinical practice guidelines for prescribing opioids and is available to public commentary as of February 10th, 2022, only a couple weeks ago. Now, I'd like to take a little bit of time to briefly discuss some training and experience in addiction medicine. This part is mainly for pointing for physicians towards the American Board of Preventive Medicine pathways to achieve subspecialty certification. Addiction medicine is one of the newest medical subspecialties recognized by the ABMS, American Board of Medical Specialties, in 2016. There are a few different routes toward obtaining subspecialty certification in addiction medicine. Now extended through 2025, the practice pathway allows physicians the ability to apply for subspecialty certification without formal fellowship through experience, education, and a defined minimum time in practice. While I can't emphasize enough the value of formal fellowship training in addiction medicine from the sheer scope of practice, I do want to encourage as many of you as possible to find ways to expand your practices to include the field of addiction medicine, as I truly believe that it impacts every field of medicine. As a primary care physician, I also feel that we have an obligation to patients that we serve to recognize substance use disorders as a chronic disease that we should be comfortable treating. I'd like to thank everyone for their attention, and I am happy to answer any questions, discuss my experiences practicing as an addiction medicine fellow at the University of Washington Boise Addiction Medicine Program, and happy to go over any of the research or some of the neurobiology that I discussed.
Thanks, Jeremy, for your talk. I really appreciate it, very much so. There's a couple questions, and if you want to look at them for a second, you're free to answer them as you see fit. We had a couple that we answered live. The course code is CDC PMRF, all capital letters, if you need continuing education credit. You see ones there you want to look at, or you want me to read them off? I'm happy to do so.
Let's see, I'll kind of read them as we go. So I love the first one that I'm seeing. Also, what about depot injections for buprenorphine? So yeah, monthly. So Sublocade is something that we use pretty frequently. Once we have a patient stable on a Suboxone dose, this is a monthly injection that we can give patients, and it's in the abdomen. It's pretty interesting when you actually inject it. It creates this little gel-like feeling just above the rectus abdominis over the stomach, and you have to change the area every time you do it. So there's 4 different quadrants we look at in the abdomen. But yes, there's great evidence for the use of Sublocade or the depot injection as mentioned for buprenorphine. Let's take a look at some other questions. So one of it's more of a comment, but will you discuss opioid prescriptions in kids following surgery and percentage leading to addiction? My experience shows that docs are still prescribing opioids to kids following surgery, even when not needed. Tylenol, Advil are excellent pain relievers and are non-addictive. So this is an area I feel quite strongly about. So my background, I didn't mention beforehand, I was a general surgery resident for a few years before switching to primary care and then going and doing addiction training. But yeah, I think that's one of our major opportunities to where we can impact opioid prescription limits and decrease rates of opioid use disorder would be in the perioperative period. So one of the things that I'm looking at specifically with a project with Idaho Medicaid's population is looking at the type of provider, trying to figure out if, not like pointing fingers at anyone, but seeing if there's like different subspecialties that are larger culprits for prescribing longer duration of opioids, and figuring out, are there different ways, not necessarily like changing the prescription, but are there different things? Can we make sure we do additional training? Are there things we can do with these providers to help curb the opioid epidemic? So I love that comment. Scrolling through. So one comment was, how does addiction or treatment account for early childhood trauma in users as a component to assess and treat? While I feel like I don't have the eloquent explanation that some other addictionologists might, I would love to point out there's a brilliant addictionologist, I believe out of Vancouver, named Gabor Mate, who's been practiced addiction medicine for a while, that has a series of videos that discuss just this and how a lot of addiction is rooted in early childhood trauma. So I would point you in that direction. Gabor Mate is the doctor. There's a lot of similar questions. One question was asking about my experience with different forms of treatment for smoking cessation. And my experience mainly has focused on nicotine replacement therapies, patches and gum, varenicline, and bupropion. So one question was, what was the name of the fellowship program I mentioned? And yeah, I would love to encourage, University of Washington, Boise Addiction Medicine Program. It's here in Boise, Idaho, and it's been just phenomenal training. I've gotten excellent training in both inpatient and outpatient training settings. So I would encourage you to, if for those interested, if you're interested in more training, you can look up that program and take a look and reach out. Yeah, we're always happy to talk with folks about getting you more engaged and then looking at the program here. So a really, really good question here. Why do you think a lot of doctors prescribe higher doses of buprenorphine, so greater than the 16 to 24 milligrams, when low doses such as 8 to 12 milligrams can be sufficient for treatment? This is an area I'm pretty passionate about because there's just great research on it. So FDA approved up to 24 milligrams, but again, like I mentioned, there's a number of randomized control trials that do show efficacy at that 32 milligram mark, which there's really no reason to go beyond that. And the main reason, you can take increasing doses, but because of that ceiling effect that I talked about, of the partial agonist effect of buprenorphine at the mu receptor, even if you're taking 40, 48, 56, you're taking higher milligram doses, the serum levels that you get are going to be negligible difference. Yeah, it's important to encourage that. There's very, very limited scenarios that I've ever seen. There are some induction pathways through the liver, cytochrome P450, I believe it's like 3A9 or 3A4 maybe, where if a patient's taking another medication at the same time, I can think of an example like an antibiotic that induces that cytochrome P450 mechanism, that you might need a little bit higher doses just while you're on that medication. But other than and that's purely theoretical. But other than that, there's not really ever any business prescribing more than 32 milligrams. So for one of the questions is, what do you recommend for early learners regarding patient-centered language when addressing a positive screener or test for the first time? I'd love to point you out the resources that I have used in here, especially the ones at the beginning of the lecture, which I think you should have access to afterwards, but they're all taken from SAMHSA sources, as well as some ASAM sources. So looking through, and the thing is, not all these are intuitive. So I don't want folks feeling bad when you don't know the correct terminology, because it has evolved. I mean, a number of clinics are still called detoxification clinics, though we're shifting that verbiage to recovery clinics. Even the term medication-assisted therapy has been implicated, is stigmatizing. So we're switching medication-assisted therapy to more specific names like medication for opioid use disorder treatment. So I don't want folks to feel bad, but I do want you to pay attention to some of the resources and really familiarize yourself with which of these words might be stigmatizing. Still scrolling through a couple questions. There's a couple excellent questions too that I don't know the answer to off the top of my head. So I'm going to save some of these and try to respond offline. I'm trying to make sure I get the ones from all the anonymous attendees, because it'll be less easy to get those answers. Yeah, I think for now, yeah, those are the main questions. I appreciate these. I'll make note of some of them that I didn't get to answer here, but yeah, I definitely appreciate everyone's questions. And this is a topic that I'm absolutely passionate about. So if you ever want to dialogue offline, I'm happy to discuss more and kind of go over different treatment modalities. I intended in this being a diagnosis and treatment session, but after I started putting this together, I realized that would have been far beyond the scope of an hour, because honestly, it's a lifelong learning process, and it's certainly within the scope of a year of fellowship, learning all the nuanced treatment plans. But I do encourage all of you to look at resources to getting more training, because addiction medicine, while itself is a subspecialty, there's addictionologists. I feel like everyone delivering, especially primary care, but delivering care to patients should have strong understanding of addiction medicine, so we can take this, because it affects our patients. I mean, we saw the use patterns in the United States. So whether or not you know and ask about it, it's still happening with the patients that you treat.
Jeremy, I had a couple questions, if you don't mind.
Sure.
So I was wondering if you could talk a little bit more about jurisdictions within Idaho, and in there's a number, I see there's a number of state and local health department folks online. And so if you could talk a little bit about jurisdictional differences in how they're addressing the opioid epidemic and substance use disorder that you might have come across in your work in working with the court system or other manner.
Yeah, so certainly different practice patterns have seen, and that's one of the areas when initially seeing some of the what we have available on prescription patterns, there are definitely different factors that are affecting prescription in different areas. I think this is largely going to be a function. This is part of the analysis that we're going to do on looking at the geographic location, but then looking at the types of providers that are in the different areas. I think that's probably what's most contributing to the variable amounts that we're seeing in prescribing behavior for the initial opioid prescription, and then subsequent prescriptions after that. I'm sure, and that's something we'll probably have to investigate a little bit more, because rather than just the provider type, there might be some, like you're saying, jurisdictional differences that are affecting some of these patterns there. So that's something I'll have to explore a little bit more, and I think would be probably a really good area to look at, because it very well might not be implicated just because of the provider type.
Yeah, and it strikes me particularly because prescription of controlled substances is regulated nationally, but then there's some components of state regulation. Could you, and that's more my own naivety about that practice, could you talk a little bit about that, and how, say you're in a health department and you wanted to do more in terms of policy at the county level, are there ways in which you can do that in relation to opioid, maybe not in prescription practices per se, but actually in the treatment they're in, or screening and treatment?
Yeah, one thing that absolutely comes to mind, I mean, in the state of Idaho, we have a program called Project Echo. It's in a couple areas in the Pacific Northwest, and I think probably beyond that, but where we meet, there's a couple different ones. I'm part of one of the panel, as a fellow on the panel for opioid use and area, and there are stakeholders do attend some of these meetings to kind of see what the current practice patterns are, and then get guidance from the, quote unquote, like the leading experts in the state on treatment of substance use disorders, and specifically like opioid use disorders. So that provides, there's the state of Idaho's, it's like many states where there's a couple big cities and then there's a vastly rural population, which is pretty much gets all their care from primary care and refers a lot of things out if it needs to. But this provides an opportunity, and we try to engage with providers, but also stakeholders in these different areas in order to provide, like, hey, here's why we don't go beyond 32 milligrams of buprenorphine. That's like a talk I've given beforehand, talking about the pharmacokinetics. So engaging providers and stakeholders in those manners for both diagnosis and treatment.
And I don't know if there's so much variability in where clinics are located for low resource populations, but I don't know if in Idaho there's opportunities to partner with the clinic, like the health departments and their clinics that are serving low resource areas, in terms of whether that would be a hotspot per se or hotspot's not the right word, but this ability to have a high impact in affecting prescriber practices in a population that's quite vulnerable.
Yeah, I think it's probably the highest impact area is like using health departments as that resource. So yeah, and that's certainly some of the things I know we're doing a lot of, like in the project that I'm doing a lot of assessment and analysis, but I guess that's all for naught if we don't have ways to like affect change, if that's what we end up wanting to try to do. So yeah, I think what you're pointing out is imperative that we engage the stakeholders at like the local community health department levels.
Yeah, and I do think that there's been some work in the past in the residency side of the house of the preventive medicine residency that talking about needle exchange programs, and although maybe that's sort of a whole nother tangent on substance use disorder, but I think there's also some component of county health departments being able to be involved in those type activities. And then one question in your experience, maybe gaining entree into the county, the clinic, the court system, and ways in which you think early learners or mid-career learners can get more involved in the policy side of substance use disorder, impacting substance use disorders at the state level. Sort of, maybe you could talk a little bit about your experience in how that has evolved over time as you engage with that system, and then how the facilitators and barriers therein, if you will.
Yeah, while there are barriers, I haven't hit a ton within the field of addiction medicine since here in Idaho. So, I mean, I've been able to pretty easily get involved with our local Medicaid director, who's very enthusiastic, because this is like an issue they've looked at prior to me even being in Idaho, something that's affecting all the US for that matter. So weren't too many perceived barriers getting involved with that. And yeah, that's been a wonderful opportunity. I've also had the other part of the population health training in place program that I've done is a programmatic evaluation. So I've worked with Idaho Treatments Court. So specifically, I'm working with Veterans Justice Outreach, and I attend court weekly and have worked with a number of key stakeholders in the state, trying to look at what different areas. So when I say treatment court, I mean individuals who are involved in the justice system related to substance use. And there's a lot of published outcomes, good, bad, but a lot of good outcomes for folks when they're engaged in a treatment court specifically versus another court when they've been involved with substance use. So I've been able to engage pretty easily, like with our states thing. So I haven't had the experience, I think, to speak on barriers. I think in addiction medicine in general, if working with some of the like Medicaid and Medicare payer systems and say, hey, if you're interested in engaging in some policy work, come about with a specific interest. I came with a kind of defined thing. I want to do a policy evaluation of the specific act of CARA 2.0, which would look at day limits. And so I think if you have like a specific question that you're wanting to look at and you come to the right stakeholders, it's at least from my experience, been pretty smooth sailing. Because so many folks, there's not a ton in medicine that are involved in addiction medicine and substance use treatment. So folks that are interested in that, it's a great area for all this like population health and public health practitioners in general. It's just an area such ripe for research to look at some of these implications and can affect so many patients. So I would say if you're interested, you probably not be met with too much resistance, like my own experience.
And one of the things I've run across over the years is this idea of state managed public health funding versus locally managed public health funding. And I would imagine that there's some components at play in Idaho and any state you work in as to who controls what, and where it's almost like trying to find the right person to talk to, right? And that can be onerous in itself. But once you think you get connected into that person, it's really been beneficial. And then finally, as if you could talk a little bit about, I noticed that SAMHSA has provided flexibilities on opioid use disorder or substance use disorder treatment during the pandemic. And I wonder if you feel comfortable, if you don't, it's fine, to talk a little bit about how those have affected substance use disorder or addiction medicine during COVID, and then the anticipation of when the public health emergency is declared over, because I think they're tied to those two.
Yeah, without speaking on like just because I'm not familiar with like federal and like all the state legal implications of it. I mean, COVID I've practiced, in primary care and full scope family medicine before, addiction medicine. And I think COVID, especially states that have gone into like crisis level of care a number of times, has really pushed what we've been able to do virtually. And then because of the strain on patients being hospitalized and filling up the hospitals, patients that we would routinely be like, yeah, you're seeing them in the clinic, and you would send them to the hospital for like management of their alcohol use disorder. Well, there's no beds, and the patients are aware of this too. I mean, it's stuff that's, in the news. I mean, we're pushed more and more to do things virtually, but also doing things in the ambulatory care setting. And I think, I haven't seen anecdotally any like bad outcomes. I'm sure there are a number of those, and I don't want to like discount those by any means. But I do think it's driven a lot of innovation in terms of utilization of virtual check-ins. I know I am. Since COVID-19, I am much more apt to like, hey, can we do this, if it's appropriate, do this follow up, virtually, whether we do it on video or we do it over the phone. Not usually like for first time prescribing for things. It's good to have people in because you're frequently getting lab work and things like that during the initial visits. And but yeah, I feel like it's an area that's huge and ripe for taking for telemedicine. I know we've had a couple talks in these grand rounds about the explosion of telemedicine, and I think substance uses are ripe for the picking with that. I think in the appropriate setting, though, as long as it's done in the appropriate setting, I think it's just another tool that we have to provide access to our patients, especially those that are in areas that might not have an addiction medicine provider or a primary care provider that's offering addiction treatment.
Yeah, I have a proclivity towards telehealth as well, and so we had talked about it a number of times during check-in. Do you think one of the topics of debate in telehealth, and I'll let you go, sorry to drag you across into my telehealth space, but is the idea of audio only check-ins versus video and audio? And I was wondering if you could, if you feel comfortable, if you don't, it's totally fine, to talk a little bit about that in substance use disorder treatment, and whether there's truly a difference in established patients who you're working with in a telehealth basis through audio only. I think in the end, you could probably just caveat to say, hey, I have to work with the individual patient as they are. But I was wondering if you could talk a little bit about that, or if not, it's fine too.
Yeah, I can speak as much, anecdotally. I mean, there's some things that you need to see, and I mean, you ideally see in person. When I'm assessing a patient for, especially withdrawal, I mean, we have clinical tools that we use to assess and go through like criteria, and you get vitals. I mean, they're not like CWA is one of the common ones that we use to assess someone's like scale of alcohol withdrawal. But part of that, we also look at their vitals and see. So if there's a high likelihood that a patient can end up hospitalized for a medical condition, I think it's imperative to have them in person. Then the decision point is, okay, if there's not like a high risk of a bad outcome, the video versus phone part. And I would just say, I don't have the answer to that necessarily. I know I utilize both. I'm trying to think of what prompts me. Usually I don't think I have a great gestalt on when I'm typically offering video. I give patients preference usually of like video because that's available access. It doesn't really change my work pattern. I'm sitting at a computer either way and talking and there, but I do think it adds something. I mean, I'm not old fashioned in this, and I love the physical exam. I think you gain a lot from, talking and working with patients face to face. That being said, just being able to increase access through virtual care, though, I'm a big fan of like patients that previously had to drive 2-3 hours to get care from, primary care or subspecialist. I mean, now we can do a lot of this virtually. So that's a lot of me talking to say, I don't necessarily have the gestalt. I do like phone visits. I mean, I do think they offer. I often will default to those when the patient's like, oh, I can't get video working, and do just phone because issues with technology and that part. But there are situations where I think those, but that's something I need to carve out a little bit better when I want video versus audio.
No, I think it's particularly pertinent in a state such as Idaho with a really can be very, very remote population. And one of the metrics in telehealth has always been this transit time between for patients or providers to one or the other. And I think that there's probably a lot of utility in being able to measure that in the future, and particularly with addiction medicine. I think populations that may or may not have access to internet at different times I think that there's opportunities there to provide a better access with audio only follow-up rather than audio plus video. But at the same time, I always feel at CDC we're worried about the patients right in front of us. And then on the CMS side, rightfully so, the Centers for Medicare and Medicare Services are worried about fraud, waste, and abuse, which is a legitimate concern as well. So I very much appreciate that. I don't see anything else in the chat, but if you want to take a glance at the chat one more time, there's a couple more that came in. But see anything else in there? On the bottom probably. If not, it's no big deal.
Yeah, I think I might try to answer some of these offline for the ones that have some names. Yeah.
No problem. No problem. All right. Well, thank you so much, Dr. Blanchard. I really appreciate it. And I've genuinely enjoyed working with you over this last 8 months or so. Boy, closing in on the end of our fellowship time, but it's maybe 7 months. Thanks again for taking time to present, Jeremy. I appreciate it. If you're one of our avid listeners, we're going to be back on April 6th, the same time, same place, in whatever time zone you are. Take care, everyone, and stay strong. As always, thanks to Lillian and Rich and Gabby and Laverne for putting this together and making sure this all comes to place. Thanks, everyone. Take care and stay strong. We'll see you next month.